Hi, good evening. Can you hear me?
Yes, sir. Can hear you.
Okay. So how many of you in the batch? How many in
34,
the
I think.
batch? Huh?
30, about 34.
Okay. Now only I see about 15. So should I wait for some time or
Shall we wait for about few minutes, 1 or 2 minutes?
so shall we start then? For the interest of time, now it's 9:40.
Okay, sir.
Okay. So I am Dr. Maithri Rupasinghe. I am a senior lecturer and the head department of family medicine, Ragama. I don't know whether I have met you before uh, in person, but you must have probably met me before in some sort of a family medicine forum. So, I consider it's a great privilege to do this lecture to you all uh, on principles of patient management in general practice, which is very vital when it comes to a practicing general practitioner. So, few learning outcomes after this lecture, and hopefully after going through this lecture, we'll be able to apply core principles of patient-centered management in acute and chronic illnesses And also you'll be able to integrate holistic evidence-based approaches to elderly care, which is very vital because lots of elderly patients are cared in general practice by you all. And also you'll be appropriately triage and manage emergency presentations in general practice. And also you probably will demonstrate clinical reasoning through scenario-based discussions. So probably every day you may be seeing uh, patients with acute illness, chronic illness, and sometimes elderly patients, and sometimes patients who come as accident and emergency. So you'll be able to reflect upon all these clinical scenarios, and you'll be able to make a personalized plan for these patients when it comes to managing these patients. So that is the idea of going through the principles of management in general practice. The outline would be, I'll be giving you an introduction to the principles of general practice. And also we'll be discussing the management of acute illness, chronic illness, elderly care, and also accident and emergency. And I'll be discussing a case at the end of each session. And also we'll be discussing a little bit on common things that you consider as management principles, and also few take-home messages. You can ask, you can disturb me and ask any question if you find it difficult to, understand what I say. You are free to disturb me, right? Okay. So uh, first, the introduction. Of course, when it comes to scope of general practice, you know that general practice is the first contact uh, to patients when it comes to their problems. The first contact is the first contact with the healthcare system. So general practitioners are the first contact with the health system most of the time. And there can be other practitioners who will be, giving first contact care, but most of the time it will be the general practitioner. And also the general practitioner gives continuous care, which can be, the continuous relationship, and can be continuous, whatever the information that the patient gives to you. So you give continuous care, which is seamless. And also you'll be giving comprehensive care where you consider the physical, psychological, social aspect of the patient. And also you give curative care and you think about health promotion and disease prevention. Not only that, you think about the person and also his family and the community the patient lives. So if you think about all these things, you give comprehensive care, and also you coordinate care. When it comes to care, you will not be able to give all the care to the patient. Sometimes you'll have to get the opinion of other people as well as including specialists. So you'll be coordinating care to the patient to get such care. And also the care that we give is adaptable to community context and resources, because we are not having all the resources that the hospitals have. So we try to give the maximum care with the resources that we have in the community. And also we play a key role in prevention, early diagnosis, uh, because most of the time the symptoms that a general practitioner sees may not be, very clear sometimes, because there is lots of uncertainty when it comes to, early presentations of a disease. And also you give long-term care when it comes to patients who have, chronic illnesses. And in a nutshell, you bridge the public health and clinical medicine, right? So you try to bridge the community with clinical medicine. So you are the bridge, right? And when it comes to core principles of patient management, or principles of patient management, you most of the time give patient-centered care. The patient-centered care is you do not only consider the physical illness, but you consider the illness experience of the patient, where you consider the psychosocial aspect, the patient health beliefs as well. And also, you will not force the management to the patient. You give shared decision making, right? You always ask the patient, can you do this? And is it possible for us to do this? That sort of story. And also, as I said earlier, you consider the biopsychosocial model of health, where you consider taking a history and try to examine the patient and try to come to a differential diagnosis and give physical treatment to the patient, as well as on the other side you will try to explore into the patient's lifestyle, their beliefs, their psychosocial stresses that they have. All these will be taken into consideration, and you consider both and institute management to a patient. So that is biopsychosocial model of health. And also you give continuity of care, and long-term relationship is one of the key things that you have in general practice, because the relationship built at the first consultation will become strong with further consultations. And also, one of the principles is effective communication and empathy. We are good communicators, and we can, empathize with patients well because of the long-term relationship we have, and also the strong relationship we have. And also, we do not only empathize and we try to, have a long-term relationship, but as general practitioners, we practice evidence-based medicine, and we are resource conscious as well when it comes to managing whatever the things that we have. We try to do beyond that, we try to send the patient to a hospital. So we try to give evidence based and resource conscious interventions, right? We can't do certain things in general practice when it comes to the resources we have. Such patients we should promptly send to the hospital. So when it comes to clinical reasoning in primary care, uh, we manage lots of uncertainty and incomplete information, because to assess a patient, we have only maximum 10 minutes and sometimes less than that. Within that time frame, sometimes the information we gather may not be 100%. And also, most of the time, there is uncertainty that is prevailing, which we'll have to tolerate, because whatever the patient says may not be 100% uh, guiding you to a diagnosis. And also use risk stratification and watchful fating is one of the things that we do. And sometimes as we go on, we assess the risk of a patient, for example, cardiovascular risk of a patient. And also if there is something that we can't understand, which seems to be something like a red flag, we sometimes do watchful waiting to see whether the patient is deteriorating. We do that very frequently in our practices. And also we apply safety netting strategies. We tell the patient about the red flags, explain the patient about the red flags, and ask them to return in the event if such things happen. And also we consider psychosocial contributors of the patient's complaint, because we do not only think about the physical illness, we know our patient well. So we are in a better wicket to consider psychosocial contributors to illness as well. And also we reflect regularly to improve diagnostic accuracy, because you as experienced general practitioners may have seen lots of patients. You may have made mistakes. You may have not done the correct thing to a patient. So reflecting upon regularly on these things to improve your diagnostic accuracy and your management accuracy is very important. So these are the clinical reasoning skills that you have to develop in primary care as a general practitioner. So with that, let's move to acute illness management, which is one part of, one big part of this lecture. So what are acute illnesses? Acute illnesses are sudden onset symptoms needing short-term management. It can range from minor illness to a life-threatening illness, as you know. And some require rapid assessment, and also most of them require rapid assessment and prioritization, because in the waiting area, sometimes if your receptionist says that such a patient is there, you may have to prioritize that patient before seeing other patients. The common things in general practice you see as acute illnesses may be fever, which is a very common thing you see nowadays, and also chest pain, could be some GI issue like uh, diarrhea. So maybe the common things that you see as acute illness. So as you will know, GP plays a key role in early intervention. And if the patient cannot be managed in the primary care setting, we always refer that patient to a secondary or tertiary care setting. So what are the principles of acute management? We have to recognize red flags early, because when a patient comes with acute complaint like chest pain, you will have to find out whether this is a retrosternal chest pain, whether the patient is having, autonomic symptoms. Then you think about, acute coronary syndrome. So you have to recognize red flags early. And also you have to stabilize the patient first and diagnose second. Sometimes you may not be able to diagnose straight away when it comes to analyzing the patient. You'll have to stabilize the patient and then diagnose as the second thing as diagnosis. And also use the ABCD approach, where appropriate, which is airway, breathing, circulation, disability, and exposure. And we'll have to use these tools when it comes to assessment of an acute patient. And also we'll have to treat and observe. And if the patient is not improving, or if the patient is cannot be managed, we'll have to refer. And also we have to communicate clearly with patients and families, which is sometimes not happening in our setting as well, which needs to happen. Unless you communicate well, sometimes there can be issues that can crop up due to mismanagement and that sort of thing, where you have done the correct thing, but see, the patient didn't understand, or the families didn't understand what you did. And when it comes to acute illness, initial assessment framework includes a history taking, which is brief, and you should find out the onset of the symptom, the duration of symptoms, and associated symptoms briefly. And you may not take a very lengthy history when it comes to acute illness. And you'll have to do a brief physical examination, which should be focused and efficient. You can't, go on examining the full system sometimes when it come to acute illness. And also it's vital for you to assess the vital signs like temperature, blood pressure, pulse, oxygen saturation, etc. when it comes to acute patient. And also it's very vital for you to assess the ABCD of patient and use clinical judgment to guide investigations, because you not be able to fully analyze the symptoms at that acute occasion to really decide by clinical reasoning. So your clinical judgment is the best guide for you to plan the investigation. For example, if the patient is having retrosternal chest pain with autonomic symptoms, you should go ahead and do a ECG immediately. And the management approaches of acute illnesses, uh, you have to treat based on most likely diagnosis. Sometimes you might not be able to confirm the diagnosis when it comes to acute illness, but you will have to consider the most likely diagnosis. And also prescribe only when necessary. Sometimes the medications may not be necessary, and it's just reassurance and probably giving some symptomatic relief for the patient, maybe the thing only need at that moment. And but you should give clear instructions on symptom monitoring to the patient, because the patients are ambulatory patients. They'll go home and they will think about the new symptoms that is appearing when it comes to acute illness. So you should always give clear instructions what next can come as symptoms, and also about symptom monitoring. And also you should provide safety netting advice, which is very vital when it comes to acute illness management. And also you should schedule a follow-up or review when needed. So you should treat, prescribe if necessary, give clear instructions, and provide safety netting, and schedule a follow-up review when needed. So it's very vital when it comes to management of an acute illness. Uh, Follow-up and review, you will have to reassess if no improvement. So you should tell the patient to come back and encourage return if symptoms worsen. And you should monitor treatment responses and ask, you can empower the patient to monitor as well. Or you ask the patient to come back to your office and, you see whether the treatment is, responding, especially antibiotics or anything like that. When it comes to response, if the fever is not settling, you will have to do something about it. And you have to adjust the plan as needed. And very important, document all decisions clearly and most of the time which is not happening, right? You have to maintain a good medical record when it comes to even acute illnesses, right? And also, it's very important to respect the patient's beliefs about illness when it comes to cultural and resource considerations, and use available diagnostic tools wisely, because there are enough diagnostic tools that can be used in general practice setting when it comes to acute illness, and also educate about traditional versus modern treatment. Sometimes the patient may be really overwhelmed by traditional treatment, but still you should subtly, without hurting the patient, you should explain the modern treatments available and how safe they are. And also should consider affordability and accessibility of the treatment. No point in giving the best of best treatment which is not affordable to the patient and also not accessible to the patient. And also sometimes, in general practice setting, you may not be able to give the ideal care. So you have to balance the ideal care with local limitations. So you may not be able to give the best of best when it comes to general practice setting in anywhere in the world, right? So you have to consider all these things when it comes to management of acute illness. So let's take a scenario. Now, this is a patient, 32-year-old, with fever, myalgia, and rash of 2 days duration. Uh, so can someone tell me how we are going to manage this acute patient? Kosala, what are the things running through your mind? Kosala, are you with me? Then if he's not, he's probably sleeping. So Madhumali, can you just come out? What do you think this is?
Yes, sir. My DD are dengue fever and also viral fever.
Okay.
Mm.
So what will you do to this patient?
I'll take a detailed history and
Okay.
examination.
Okay.
Mm. Then I'll order investigations, full
What
blood
sort of
count,
investigation?
full blood count,
Okay.
and CRP,
Okay.
and dengue antibody if relevant,
Is it antibody or antigen?
antigens.
Okay.
Yes.
Then,
Mm. Then I would like to start on uh, manage the patient with paracetamol and basic drugs, and
what are
to
the
advise
basic drugs?
if the patient is having vomiting, I'll give domperidone,
Uh-huh.
10 milligram TDS, and if the
Okay.
patient is with uh, GORD symptoms, I would like to give some PPI.
Okay.
Um, And if as the patient is with myalgia, I would like to give Panadine, that is paracetamol plus codeine instead of
Okay.
paracetamol.
Okay.
Likewise, and I advise the patient to take enough fluid, uh,
Okay.
liquids, and to rest mainly.
Then,
Then I'll review the patient with investigation reports.
okay.
In
Excellent. So that is what you are going to do, are you?
yes,
So,
sir.
so differentials nowadays, of course, you have chikungunya as well, in addition to common viral fevers, dengue fever. So you have to see whether the patient's vital signs are stable after taking a history, after examination. If they are stable, then as you say, you advise regarding fluid and safety net the patient regarding warning signs before sending the patient. Ask the patient to do a full blood count, dengue and S1. And you're going to manage this patient at home with daily review. So probably that is what you are going to do, right? So this is what you should do when it comes to acute patients. So these principles are, but when it comes to, answering a question or probably, doing a presentation, you may not be able to do it. So that's why, you have the experience, but, I'm trying to just give you some basic principles to understand what you are doing at the moment, right? So when it comes to acute management, this is what you do practically. And, theory wise, you have to think what you are doing retrospectively when it comes to family medicine theory, right? Okay. So that is acute management. So with that, let's move to chronic illness management. Now, chronic illnesses are lifelong illnesses, sometimes, lasting more than 6 months. It may not be a time frame, not be a matter. It is a chronic illness where it lasts long, maybe sometimes lifelong. For example, as you all know, diabetes, hypertension, COPD, and even asthma, all these things are uh, chronic illnesses, and it's a major public health burden in Sri Lanka because a long time ago infections were the major public health burden. Now non-communicable diseases are the major public health burden which we struggle to manage, right? So these patients require long-term engagement and coordination, which is never happening most of the time when it comes to public secondary tertiary care setting where the patient just goes and get some medications and come back. And also prevention and early detection are crucial when it comes to, uh, you know, uh, uh, chronic disease. So general practitioners play a vital role in management of chronic disease. What are the core principles of managing chronic disease? It should be holistic and person-centered care. And you just can't give a generic treatment to a patient, say you take metformin and glycoside and aspirin and losartan and just send the patient off. So it should be decided by analyzing the patient and the context. Context is the patient's surrounding. And also it should be, streamlined to the patient's needs and, whatever the patient's characteristics. So if you do that, uh, the chronic disease management will be successful. And also emphasis should be put on self-management support because, most of the time the patient may not be able to see you immediately when it comes to a chronic disease. So the patient should be given enough support to manage their illness on their own. And also it's very important for you to prevent complications and prevent hospitalizations, which the patient may like very much because they don't like to go to hospitals and get admitted and, try to get treatment, and they don't want complications as well. So yeah, one core principle would be to prevent complications and reduce hospitalizations. And also you should, you as a general practitioner is in best place to encourage the patient to do lifestyle modification. So what are these lifestyle modifications? Could be smoking, it could be, alcohol, it could be, diet, it could be exercise, and it could be, weight that is causing problems, weight reduction. So you have to talk about these things when it comes to chronic disease of a patient in each and every patient in a way that the patient can do it, right? Not giving a generic, where, sort of thing where, you'd say you try to reduce weight and try to do 30 minutes walk. That will not help sometimes patients. So you have to understand the patient's lifestyle and, you have to streamline the lifestyle modification as well. And also you have to collaborate with other healthcare providers like specialists and allied health workers when it comes to, chronic disease management. So it should be holistic, person-centered, and you should support the patient to manage their illness on their own and prevent complications and hospitalizations. And you should encourage lifestyle modification, and also you have to collaborate with other health workers when it comes to managing chronic disease. So when it comes to doing this, there is a chronic care model which is, available, which gives you the support to do that. Now, when it comes to chronic care model, you have the community you have the health system, and you have a patient, and you have a healthcare team. So when it comes to managing a chronic disease, there should be resources and policies that are delineated, and there should be a healthcare organization, and also there should be self-management support, and there should be some delivery system design, and decision support and clinical information system, like probably a electronic system, and all these things will help informed activated patient with a good prepared proactive practical team in the general practice setting, which helps the patient to improve their outcomes when it comes to chronic disease. So the chronic care model, uh, uh, in chronic care model, it is patient-centered, team-based approach. And also you use registries for tracking and recall. And sometimes if you are using an electronic record, you can use electronic reminders as well. And you should plan for structured reviews and proactive care, because sometimes patients may lag behind. And you should have self-management support tools for patients to manage their illness on their own. And there should be decision support and care planning for patients. And you should have some plan for the patient, individual plan for the patient when it comes to chronic disease. So read about this chronic care model, which is very vital for you when it comes to deciding how to manage a chronic illness. And also in a chronic illness, monitoring and goal setting is very vital, because most of the time what happens is you give medications, but you don't give the right goal to the patient. Now, these goals should be smart, that is specific, measurable, achievable, relevant, time bound. If you can't measure it, if it is not specific, very vague, and cannot achieve, and is not relevant, and cannot be done with the time frame of the patient's life, then of course it's useless. So you have to use smart goals, like, for example, regular monitoring of HbA1c in a patient with diabetes. Now, say when you review the patient in 3 months' time, if you do a HbA1c and assess the patient's glycemic control, that is one good example for a smart sort of a goal, where you give a goal saying HbA1c should be less than 7. So like that. And also you should involve patient in setting health goals. You can't, just yourself decide the goal, and you have to assess the patient and come to a consensus that, this is the goal that I can give you after discussing with the patient. And also you should assess the barriers to, compliance to medication, because there are lots of compliance barriers when it comes to patient. For example, a patient's, disbelief that metformin is causing kidney disease may be a barrier for compliance when it comes to metformin. So if you do not address that and explain the patient that it is not causing kidney disease, then you will not be successful. The patient, every day, patient will, be non-compliant, and sometimes at the end of the thing, the patient may have complications as well. And also for this purpose, when a patient is really non-adhering and deviating from whatever the advice that you give, you have to use motivational interviewing. The motivational interviewing is not, trying to give advice or try to force the patient to do something. It is, with the patient, you try to decide what can be done. So learn about motivational interviewing as well, which is very vital when it comes to managing and changing the patient's behaviors when it comes to chronic disease. And also patient education and empowerment is very vital when it comes to chronic disease management. You have to explain the condition in simple terms, which never happens. Ask a few of the patients who come to you, who come from secondary care setting, what do you think you have? Most of these patients do not know what they have. And also you should teach how to monitor symptoms at home, right? Like say, for example, a patient, if you teach the patient to monitor the blood pressure at home, then that will be easier for you, right? When it comes to, future assessment, the patient may come with a record of blood pressures to you, so that it will be easier for you. And also you have to discuss diet, exercise, smoking cessation, and also sometimes alcohol, how to, probably cut down or stop. And also you should use culturally appropriate materials because, some certain things the patient may not agree, right? Sometimes, if you give a, health education leaflet, that may not be sometimes feasible, culturally appropriate material when it comes to our setting, but it will be a very good thing when it comes to Western countries, right? And also you have to empower the patient to take control, and you are not the person who is trying to control the patient. It should be the patient who is taking the control, and you'll be just a catalyst, a person who guides the patient. So it's very important for you to understand this, and vital for you to do patient education and empowerment. And also you must be finding lots of patients with multimorbidity. Multimorbidity is, more than two or more diseases when it comes to a patient. So most of our patients have two or more diseases, and a patient who is having diabetes may be having hypertension, dyslipidemia, may be having a little bit of CKD, and maybe having additionally bronchial asthma. So in such a patient, you have to prioritize the patient goals over disease targets. Because if you try to manage all these things the way that you want, it will not be successful. So you'll have to discuss with the patients, what are the things that you want from me, right? It's very important. And also polypharmacy, that is giving multiple medications, is the issue, right? So sometimes, you give medications and some medications to relieve this, side effects of those medications. I have seen. I'll show you one prescription later on in this presentation, a good example of this. So try to avoid unnecessary medications. Now, previously, when we were discussing about, acute illness also, and lots of people try to give paracetamol, domperidone, omeprazole, and some other famotidine to just impress the patient. But if you can, try to educate the patient that paracetamol would be the only thing that is necessary for that patient who is having viral fever, that would be the best thing that you can do to that patient. And also monitor for drug interactions, because when you give lots of medications for lots of illnesses, there can be drug interactions which can, lead to lots of problems. For example, there can certain drugs, if you give in combination, can lead to electrolyte disturbance like hyponatremia, which can lead to, confusion and all sorts of, problems in elderly especially. And also you should coordinate care across specialties, because, what happens is, the moment you send the patient to a specialist, that specialist sent that patient to another specialist. So the patient get lost among specialists. So you should not do that. You should take the lead, and you should coordinate care across the specialists, and always tell the patient, I am sending you to this person and please come back to me. So you should do that, as in our country, there is no way that the patient will be sent back to you, but you should have a good relationship with the patient, and, explain the patient the need to come back to you as a generalist. And also you should support caregivers and families when it comes to chronic disease, because sometimes chronic disease can lead to caregiver stress and sometimes family dysfunction as well. So you are a family physician and a general practitioner, you should do that. That is unique to you. Let's go through this clinical scenario. Now, this is another patient, 58-year-old lady with type 2 diabetes mellitus, and she's having neuropathy, and her HbA1c is 10%. She is on oral agents and oral uh, hypoglycemic drugs, but she's non-compliant with diet, and she complains of burning feet and blurred vision. So you should plan. Your plan should be, education, and especially with regards to the diet and exercise and drug compliance. And you should refer the patient to eye clinic, because this patient is already having neuropathy. You should see whether the patient is having retinopathy, and also should give food care advice and adjust the medications, set dietary and physical activity goals, and also you should relieve the patient's, acute symptom, which is burning. If you do not relieve that as well, the patient may not be compliant, and also will not be, returning as well. So you should do all this when it comes to managing the chronic illness. With that, let's move to the elderly care, which is very, very vital. Nowadays, of course, lots of patients, elderly patients end up in our setting because there is no one to care for them, right? They don't like to go to hospital and they don't like to be cared by other physicians as well because they give piles of medicines. So you are in a better wicket when it comes to giving elderly care. What are the unique needs of older adults? These individuals have increased vulnerability to physical and cognitive decline. The moment they develop fever, sometimes they will not be able to walk and they'll have some decline of memory as well. So there is increased vulnerability to physical and cognitive decline. And sometimes their presentations are not typical. And a patient who has myocardial infarction may not present with the typical chest pain, which is retrosternal and that sort of thing, right? The patient may be having a mild chest pain. So you should be very careful with such patients because they have less pain sensitivity. So you should assess such patients with care. And also you have, these patients have complex comorbidities which make you confused. So you should be very careful when you assess such patients and you not try to analyze one by one, try to analyze uh, them as a whole, how it affects the patient. And also you have to take social factors when it comes to assessment of such patients because lots of social factors affect the elderly people in Sri Lanka because there is no way that they are being supported by the government or any other organization. We don't have NGOs which support, elderly. And also you should focus on function because sometimes you may not be able to cure certain things, but you should focus on function and also quality of life and autonomy because they really value autonomy. They don't want to get bedbound or looked after by someone at home. So you should focus on these things: how to improve the function of a patient, how to improve the quality of an elderly person, and how to make him autonomous. So the principles of geriatric care includes care should be comprehensive, as I said earlier, should be physical, psychological, social, spiritual. And also, you should give curative care. Prevention, promotion also should be, considered. And also you should consider this individual lives in a family and in the community. And you should coordinate the care. You should organize whatever the other, care that is given to the patient in addition to whatever you give, and it should be continuous. And you should consider the physical, mental, emotional, and social needs of the patients always. And also, it's very important to emphasize the dignity and respect the patient. And independence is very vital thing. And always respect the patient preferences. You can't say, no, you have to get admitted to hospital when the patient says, I don't want to go to hospital unless it is a dire emergency. And also engage family and caregivers in planning and prevent hospital admissions where possible because they will not like it. And also they will get bad when they get admitted to hospital because of, whatever the things that is done in the hospital, if it's not really needed. And for example, now before I just, was returning from my practice, there was this, three, members of the family who came to me to discuss about her mother who has hepatocellular carcinoma, multifocal, and she has uh, uh, liver cirrhosis, and she has on and off fever, and she refuses to go to hospital, and what to do. So we had a discussion, and they agreed that ultimately they will keep the mother at home because the hospital people also said no point in getting her admitted. So I was able to have a fruitful discussion with them to make them understand that we are trying to give palliation, not trying to cure this patient. So like that, you are in a better wicket to help these elderly people when it comes to their illnesses. So when we assess elderly people, there are certain tools that we use. One is comprehensive geriatric assessment, which is a multi-domain assessment, which includes physical, cognitive, social, and functional assessment, which helps to identify frailty and reversible conditions of these patients. And it uses tools like, assessment of activities of daily living, instrumental activities of daily living, and also it assesses the cognitive function, and also it assesses the patient's mental status, like say using geriatric depression scale. And also it helps guide long-term care plans, and this involves multidisciplinary team. Now, initially, this was started for hospital setting, but now, of course, with modifications, this can be used in general practice setting as well. In elderly patients, medication review is very, very vital because polypharmacy increases adverse drug reactions in patients because they are, kidney functions and liver, abilities are, really deteriorating. So for that purpose, you can use, criteria like start criteria. Now, start criteria is screening tool to alert to right treatment where, uh, uh, medications that should be started based on clinical evidence and benefit should be decided in this occasion by using this tool. And stop is where screening tool of older people's prescription. Here, this identifies potentially inappropriate medications that may cause harm, especially when safe alternatives are available. So you may use such criteria, and also Beers criteria is another criteria. You can just go through the Beers criteria as well, which is also used in medication review in elderly. And always try to simplify the regimen to improve adherence rather than giving a medication 3 times daily. If you can give it once daily or twice daily, that would help the patient because most of the time the middle dose will not be taken by the patient. And also you'll have to monitor the renal liver functions for dosing because, elderly are not as same as, young people, and regularly we need for each medication, right? So you have to do all this when it comes to elderly people. And can someone just give me an idea about this prescription? Parvin? Yes. MCF Parvin?
Sir.
Yeah. Just see the prescription and tell me this patient has hypertension, this patient has ischemic heart disease and hypothyroidism. And normal blood pressure. What do you think about this prescription? Any ideas? Anyone would like to comment? Anyone? Okay, so now this prescription contains about 14 medications, right? So this patient has hypothyroidism and ischemic heart disease with dyslipidemia, right? All the other medications that are in the middle from number 2 to 9 were given for symptom relief. And the patient says, I can't take such lots of medications. Sometimes patient misses the vital medications like clopidogrel, rosuvastatin, because the patient has to take other medications, right? So ultimately, the patient was pleading for a, reduced prescription. So sometimes you may have to do it, and always you should respect the prescriber. But here, I thought it is quite rational for me to just continue thyroxine and lower 4 medications. The patient is very happy now, right? And she has, less cost for her medications that she can spend because, she's a retired government servant who depends on her pension. So she can barely afford other medications, but not all the medications, right? So you should think about these things when it comes to elderly people, not to give multiple medications to relieve symptoms, whatever the things that the patient says. You can't relieve all the symptoms of a patient when it comes to elderly patients, right? Okay. So see how irrational sometimes when prescriptions are written. This is not a prescription written by a general practitioner anyway. So when it comes to elderly care, you have to screen for elder abuse and neglect, right? It's very important, which is a thing that we don't think sometimes in general practice setting. And you have to assess support systems and caregivers train, which we are in a better wicket to assess and
මම එන්න හිතක් ඉන්න.
help.
මම
And
මේක අහනවා එන්න. ඈ?
and can you just mute your mic? I can overhear someone speaking. So you have to assess support systems and caregivers train as well, because you are a family physician. You deal with all these people, so you have to help the family as well. And also you can link community resources as well, and you can have dealing with the MOH as well, as you are working in the community. And also you have to address transportation and financial issues, because sometimes the patient may not be able to come to your clinic. Then as a family physician, as a GP, you may be able to do a home visit as well. And also you should encourage social engagement to reduce isolation, because all these elderly people, most of the time, they're isolated and they get depressed. So you should help them to come out from these places and try to get mixed with other people, helping them to socialize. And also, as I say, sometimes general practitioner grows old with people, and some patients you may be having who need end of life care. So such patients, you'll have to discuss goals of care and advance directive. What is advance directive? It is a legal document that allows individual to designate a health care proxy to make a medical decision on their behalf if they become incapacitated. Uh, specify preferences for medical treatment, including life-sustaining measures, organ donation, end-of-life care. But in Sri Lanka, of course, there is nothing like this, but you can discuss these things with your patients so that it helps the patients to decide what they have to do in future when they are really conscious and alert and sane. And also you should focus on comfort of patients in such patients, and you should help the patient to be dignified, and dignity should be taken into consideration. And always you should consider symptom control. You should not let the patient be in pain, considering that of the side effects of medications. Here side effects of medication is not an issue. Here you have to control the patient's symptoms. And also you have to communicate prognosis honestly but sensitively, and also involve family in decision making if the patient really agrees. And you'll have to coordinate with palliative care services, and sometimes part of palliative care is given by the general practitioner. So let's go through a clinical scenario of an elderly patient, a 79-year-old with 2 falls in 2 weeks with mild confusion. This patient is on multiple medications, including antihypertensives. Comprehensive geriatric assessment reveals patient has postural hypotension and mild cognitive impairment. Probably the intervention that you should do would be prescribing certain medications because of postural hypertension, and home safety should be looked into. And the patient may need physiotherapy because this patient may be having stiff joints, weak muscles. And you may have to refer for cognitive assessment too, especially sometimes if you are unable to deal with the dementia that she has or the mild cognitive impairment the patient has. So you can do lots of things when it comes to an elderly patient as a general practitioner. With that, we are going to move to accident and emergency in general practice. Now, common emergencies in general practice may include chest pain, a patient with dyspnea, a seizure, trauma, anaphylaxis, and acute severe asthma, right? So GPs often will be the first contact for these, emergency visits, right? If you are, working in a rural or semi-urban setting, you will be the first contact. So these patients need rapid triage and early action, right? And also you should know the standardized protocols where possible. For example, if a patient comes with acute severe asthma, you should have a protocol where what you are going to do in your practice. And also you should know limits of in-practice management, and you should not go beyond that because you will not be able to, do that in your practice setting, right? You can't start a magnesium sulfate infusion for a, acute severe asthma in your practice. So you should be sending this patient after stabilizing to a tertiary or secondary care hospital for that purpose. And also, when it comes to accident and emergency, you have to identify the airway, breathing, circulation threats immediately, and you have to categorize this patient as urgency. There can be three categories broadly you can think of. One is life-threatening, second one is urgent, third is non-urgent. And you can use tools like News 2, which is National Early Morning Score 2. You can refer this. Just go through this after this lecture to see how how you are assessing with this tool. And also you can use a simple tool like AVPU, where A is alert, V is verbal, P is pain, U is unresponsive to assess, acutely ill patient. Uh, and after assessment, you'll have to stabilize this patient while arranging transfer. And also you have to remember that you have to document vital signs and time of intervention as well, because at one stage you will be found fault with in the secondary care setting if you do not document it well in whatever the transfer form or the referral letter. And also try to follow local or WHO-based protocols. You can extrapolate international guidelines as well, but, try to follow local or WHO-based protocols. But the problem with local guidelines is they are not updated most of the time. Now, for example, in chest pain, you have to rule out MI. And, if you have the facility to do a, ECG, do it. And if, you think that clinically this patient is having acute coronary syndrome, you have to refer immediately after doing certain things like, say, giving certain medications like aspirin and all that. And if it is anaphylaxis, you'll have to definitely give IM adrenaline and oxygen and fluids, and then you'll have to transfer the patient to a hospital. If it is a seizure, you'll have to maintain the airway, and you may have to give a benzodiazepine if the convulsion is prolonged. And if stroke, you'll have to assess the patient. There are assessment tools that you can use when it comes to a suspicion of a stroke.
මේ පෞදාතියෝම කතා කරන්න එපා.
BFAST is one. Actually, BFAST is B is balance, E is I, F is uh, face, and A is arms, and S is speech, and T is time, right? Timely, referral is also very important after you assessing, right? So BFAST can be used and as an initial assessment of a stroke patient, and you have to do early referral to a stroke unit if where the patient will be best cared for. And also when it comes to communication in emergencies, you can use certain tools like SBAR or SOAP to document the patient's, a real situation, right? Situation, background, assessment, recommendation. SOAP is a tool where the mnemonic is used for subjective, objective assessment plan. So you should be clear, concise in handing over this patient to emergency services, and you should inform the family with calm, in a calm way and in clarity. You should not confuse them, and keep records of time, actions, and outcomes, because they may be needed for you in future if some sort of a legal thing happens. And also explain next step to the patient or the relations or families clearly. You should do that, because sometimes what happens is you are in a hurry, you just get flustered, you do not document it properly, and you rush the patient to a hospital, and then the patient doesn't know, the relations doesn't know, and the receiving end doesn't know what is really happening to the patient. So you should make sure that you are calm and you are clear. And you should document everything clearly and promptly uh, as legal and ethical aspects, and respect the patient's autonomy, and informed consent should be obtained, and also should be aware of medical negligence laws, and you should be very careful, and also you should protect patients' confidentiality even in the crisis or even in an emergency, and involve family when appropriate, when it comes to legal and ethical aspects of acute emergencies. And when it comes to acute emergencies, accidents, you have to accept the resource limitation, and sometimes you will have to improvise or act in a way that you use that opportunity to help the patient, right, with whatever the resources you have. So use available tools efficiently and have a basic emergency kit in practice, and always make sure that you have updated emergency kit, and develop good referral pathway with local hospitals. And you have to train staff, although in our setting we don't have trained nurses and really qualified nurses. We have to train our healthcare assistants when it comes to first response and basic life support, and also know when improvisation is needed, but safe. Now, for example, if you need to, if you see that there is a, hemothorax or pneumothorax, sometimes you may not be able to insert a, IC tube, but you may insert a wide bore needle, right? Like that, you have to improvise when it comes to, real life setting in general practice. Now, this is a clinical scenario of a trauma. Now, a 25-year-old patient, man, after RTA, comes with a bleeding leg and dizziness. So you assess primarily for airway. Airway is patent, and the patient is tachycardic and has low blood pressure. There is an issue with the circulation, right? The patient is having no problem with breathing or airway, but the patient is having tachycardia and low blood pressure. So this patient, you can't just pack up and send the patient to hospital in what sort of vehicle that is available. You have to stabilize with fluids and insert a cannula and run a drip, and you have to control bleeding. And also you have to immobilize the suspected fracture the way that you can, and you have to urgently refer with a letter to a tertiary or secondary care hospital. So you may not be able to do it 100%, but you have to do to make sure that the patient is safe. So few common themes when it comes to principles of patient management. One is cultural competence and patient beliefs are very, very vital when it comes to management in general practice, because we live in the community and we are community people. So it's very important to respect their cultural competence and patient beliefs. So respect traditional and health beliefs and practices. Sometimes some patient may be talking about Ayurvedic medications and how helpful they are. So you should not contradict, and you should, probably help the patient understand the evidence base in our medicine. And at the same time, if it is not harmful, you'll have to, probably help the patient to use that as well. And also use language patient understands. And also you should build trust to improve adherence, because the moment the patient says, I am not taking drug, if you say, if you do not take this drug, you will have kidney failure, then the trust is over. So you have to find out why the patient is not taking the medication, and find out how it can be improved and what sort of beliefs the patient has, and try to help the patient to get over that. So that is your duty. And also avoid judging alternative remedies, because sometimes the patient may come and say, තෙල් ටිකක් ගෑවා and කැක්කුම සේරම අඩු වුණා. So you say කැක්කුම අඩු වුණා, that is the ultimate goal the patient wants. So you say continue that, right? If it is not harmful. And also educate respectfully where needed, right? Okay. And now another cross-cutting theme is continuity of care and communication. Strong doctor-patient relationship builds trust. So you have to build that relationship over the time, and also keep consistent documentation of the patient's, whatever the patient's, details, and also use record systems for chronic disease reviews. And always you should have a register and find out whether the patient has not come for, chronic disease follow-up management, and try to call them or send us SMS, and also communicate with the specialists and allied health workers appropriately. And you need them, and you can't criticize them, and you may have to deal with them in an amicable way. And also you have to follow up after referrals and hospital discharge and ask the patients to come. In our setting, of course, there is no compulsory coming back to general practitioner after hospital discharge. So you'll have to make sure that the patient understand that the need for coming to a generalist after, secondary care. And also documentation and follow-up is one key theme which is important when it comes to principles of management. You have to record history, findings, plan, and advice given, and note safety netting and follow-up instructions, because sometimes patient may not remember, and you may also not remember, and you may not be able to say that I told you this. And also update the medication list and allergies, because if you do not update them, you may give a medication that is harmful to the patient, which can lead to allergic reaction. And also use standardized templates if available. You can have a standardized template where you write critical notes and all that. And also you have to do audit records of your practice to improve quality, and time to time go through your medical records in your practice and try to improve on them. So we have come to the last bit of the lecture. It will be just a summary and a take-home messages. And as I said earlier, when it comes to acute illness management, early recognition is very important, and you will have to stabilize and safety net in addition to whatever the management you give to the patient. And when it comes to chronic disease management, continuity is vital, and you have to make sure that the management plan is patient-centered, and which is can be followed by the patient. And when it comes to elderly, you have to assess the patient as a whole. Holistic care is vital, and you have to make sure that the patient is functional, and you have to respect the patient as a senior citizen. And when it comes to emergencies, you have to triage, and you have to use standard protocols, and you have to have clear referral pathways. So when it comes to managing acute, chronic, elderly care and emergencies, general practice is the front line of patient care of all these patients. Red flags and safety netting. Always educate patient on when to return. It's very, very vital. And also document red flags explicitly and clearly. Use verbal and written advice. Arrange realistic follow-up plans, because sometimes patient may not be able to come the day that you ask them to do. Come and help them to come the day that they it's feasible for you both. And monitor high-risk patients more closely, like dengue patients, because you just can't, send the patient without doing follow-up full blood counts, daily full blood counts in a dengue patient who is managed at home. So what are the future directions for GPs in Sri Lanka? Now we have to strengthen primary care system. For that purpose, we have to get together and work together and work for a common goal. And also we should have digital health and telemedicine, widely available in general practice, because most of the time we may not be able to, consult the patient in the office, and you may have to do, distant consultations as well. And also we have to expand community-based chronic disease programs. We have to get, help from the NGOs and other helpers when it comes to, and also community when it comes to doing that. And also, we have to enhance GP training and continuous medical education, because, guidelines change very frequently. So you have to be updated. And also we have to advocate for patient-centered policies, because most of the time what happens is we give disease-centered, management to patient, which is not palatable to the patient, which may not be, adhered by the patient. Ultimately, we put the blame to the patient, but really they are not patient-centered policies. So final take-home message in my lecture is, You have to treat the whole person, not just the disease in general practice. And you have to use clinical reasoning with compassion, and you can't just divulge a detail to a patient in a harsh way. And you have to prioritize safety, communication, and continuity. And you have to work within the limits, but advocate for better systems. And as you all know, general practice is the backbone of healthcare. So you are the backbone when it comes to managing acute, chronic, elderly, and accident and emergency. Thank you. If you have any questions, I'd be happy to answer. Anything that you'd like to know from me? Yes? If you have no questions, then I'll call it a day. And I managed to finish it within 1 hour, 7 minutes. So I didn't go beyond the time. Okay, thank you so much for your patient hearing. Hope that you learned something. Thank you. If you want the lecture, slides, I'll be sending it to Nimmi, and you can get it from her. Very good. Very good.